All right, so basically what we have left for the respiratory system is we have to talk about gas transport. How is it transported through the blood? And then we have to talk about regulation. How is it regulated? And it's regulated by local and then central factors. So we're going to talk about initially the gas transport. How do oxygen and carbon dioxide get transported? So both of them, both oxygen and carbon dioxide, they have limited solubilities, which means they really can't float around all by themselves. They have to be carried by something. And so we're going to look at, how are they carried? How is oxygen carried? How is carbon dioxide carried? The red blood cells are involved because they remove the oxygen and then they also remove the carbon dioxide. So red blood cells will remove oxygen and carbon dioxide, but they treat them a little bit different. Hemoglobin in the red blood cells bind to oxygen, and the carbon dioxide, when the red blood cells absorb them, they convert them into soluble compounds, which we're going to learn about, which is carbonic acid, that quickly, immediately dissolves into bicarbonate. So we'll be talking about that as well. When red blood cells do bind to oxygen and carbon dioxide, it's just temporary. And we learned this. We know that when the blood gets to the tissues, we know that the red blood cells are going to release oxygen into the tissues, and then we'll pick up carbon dioxide. And then when they go back to the lungs, they're going to release carbon dioxide and they're going to pick up oxygen. Okay? So let's look at oxygen transport. So oxygen is 1.5% of oxygen is just carried around as oxygen, as an oxygen molecule in the plasma, right? And the rest of it, 98.5% of oxygen, is going to be carried bound to hemoglobin. 98.5% of oxygen is carried bound to hemoglobin. And we talked about this before, but red blood cells have a lot of hemoglobin. They have 280 million hemoglobin. And each hemoglobin binds to 4 oxygen. So each hemoglobin molecule has 4 globular proteins, and at the center of each globular protein is a heme group with iron, and they bind to oxygen. So each of them bind to oxygen, making each hemoglobin molecule carry 4 oxygen molecules. The percent of heme units containing oxygen at any given moment is hemoglobin saturation. And if all the hemoglobin are bound, then the hemoglobin saturation rate is at 100%. If each hemoglobin carries only 2 oxygen molecules, then the hemoglobin saturation rate would be 50%. If only 3 of the 4 carried oxygen molecules, then the hemoglobin saturation rate would be at 75%. The most important factor affecting hemoglobin saturation is the PO2. So if the PO2 increases, then hemoglobin will bind to oxygen. And conversely, if the PO2 decreases, then hemoglobin will release oxygen. So basically, if oxygen is plentiful, if the PO2 increases, then hemoglobin can bind to oxygen. But if PO2 is not plentiful, then hemoglobin is going to release the oxygen so the tissues can use it. The hemoglobin dissociation curve is a graph that compares the percent of saturation with the PO2 of the blood. On this graph, we can see that as the PO2 increases, then the percent of saturation also increases, meaning if more oxygen is plentiful, then more hemoglobin will bind to the oxygen. So we can see that the graph is a curve and not a straight line like this. And so the reason why it's a curve is because when the first oxygen molecule binds to the hemoglobin, it makes it easier for the second oxygen molecule to bind, which makes it easier for the third oxygen molecule to bind. And so it gets exponentially easier for oxygen to bind. Then where the curve is steep, A small change in the PO2 can cause a very large change. So for example, if the PO2 were 20, then the saturation rate would be 35%. But if the PO2 jumps up 10 millimeters of mercury to 30 millimeters of mercury, then the hemoglobin saturation jumps up to 57. So while there's only a 10% change in the PO2, there's a 22% change in the saturation. In contrast to that, where the curve is flatter, let's look at an example up there. If the PO2 were 70, right here, then the percent saturation is 92.7. And then if we jump up to 80, a PO2 of 80 millimeters of mercury, the percent saturation only jumps up to 94.5%. So this means that with a change in the PO2 of 10 millimeters of mercury at a higher PO2, the change in the percent of saturation is less than 2%. In this case, it's only 1.8%. And so the curve is much flatter. So at a higher PO2, there's a higher saturation percentage. If a person is exposed to a PO2 of above 60 millimeters of mercury, then their hemoglobin saturation rate will be above 90%. This explains why people can survive at higher altitudes where the PO2 is lower but still above 60 millimeters of mercury. At normal alveolar pressure, which we see as PO2 of around 100, 95 after it leaves the pulmonary capillaries, the hemoglobin saturation rate is 97.5%. So this is the normal. The PO2 should be at 100 millimeters of mercury, and the percent saturation rate should be 97.5%. Complete saturation isn't going to occur unless the PO2 is excessively high, like around 250 millimeters of mercury. So you'd have to get all the way over here to 250 millimeters of mercury in order for that percent saturation rate to go all the way up to 100%. The percent of saturation drops off at active tissues. In the active tissues, they're active and they need more oxygen to create more ATP. So the 97.5% saturation drops to a low of 20% as hemoglobin releases oxygen so that the active tissues can use it. There are three factors that are going to affect how well oxygen binds to hemoglobin. One is pH, which is the chart that we're going to look at up here. The other one is temperature, which is the chart we're going to look at right here. And then the last thing is BPG. So we'll look at all of these. First, we're going to start out by looking at the pH. And first, I just want to talk a little bit about hydrogen. It's hydrogen ions that make a solution acidic. So it makes the blood acidic, or it makes the tissues acidic. So the more hydrogen you have, the more acidic a solution is. And we know that when you have high hydrogen ions, high acidity, that means you have a lower pH. When there are more hydrogen ions floating around, hemoglobin wants to release oxygen so that it can bind to the hydrogen and pull it out of solution, because it doesn't want the acidity of the plasma to be too high. The normal pH of blood is 7.35 to 7.45. So the average then would be a 7.4. The normal pH of blood is 7.4. So on this chart here, we can see the normal curve at a pH of 7.4. On here, if we look at a PO2 of 40 millimeters of mercury, and this is the PO2 that would be in the venous system after the arterial blood has dropped off oxygen at the tissues, and then the blood heads back to the heart. The venous blood has a PO2 of 40 millimeters of mercury. And so at a PO2 of 40 millimeters of mercury and a normal pH of 7.4, if we see where that intersects on this graph, that means that the percent of saturation would be around 75%. Now, if the blood became more acidic and the pH dropped down from that 7.4 down to 7.2, then at a PO2 of 40 millimeters of mercury, the saturation rate would only be 60%. So by dropping it that 0.2 in pH, the saturation rate dropped from 75 to 60%. That means that hemoglobin is letting go of the oxygen, so there's a lower hemoglobin saturation, and that way hemoglobin can pick up those additional hydrogen that are floating around in the plasma. So this means that hemoglobin releases 20% more oxygen at the tissues at a pH of 7.2 than it does at a pH of 7.4. So let's look at the opposite situation. What if the pH of the blood went from 7.4 all the way up to 7.6? So here we have less hydrogen in solution, and so hemoglobin doesn't have to bind to so much hydrogen. It'll be binding to the oxygen instead, and the percent saturation is going to go up. Again, if we look at a PO2 of 40 and we start at a pH of 7.4, which is at 75% saturation, and go up to a pH of 7.6, then we can see that the hemoglobin saturation is going to be well over 80%. Okay, now let's look at how temperature affects hemoglobin binding. Okay. So again, we have the percent of hemoglobin saturation on the vertical side of the graph, and we have the PO2 on the horizontal side of the graph. And so we're looking at normal blood temperature. The normal blood temperature is 38 degrees Celsius. So this is a little higher than the 37.2 degrees that you normally measure when you're measuring a person's body temperature. So the normal blood temperature is 38 degrees Celsius. And if the temperature were to increase, if it were going to increase from 38 degrees to 43 degrees Celsius, we're going to see that the whole curve shifts to the right, and that hemoglobin will be releasing oxygen whenever the temperatures go up. And why is this? It's because when you have an increase in body temperature or an increase in blood temperature, that means that the tissues are active. And if the tissues are active, that means they're using a lot of oxygen. So as the blood flows past those tissues, the blood is going to release oxygen so that those active tissues can use it. On the other side, if the temperature in the blood goes down, and so here we see from 38 degrees Celsius to 20 degrees Celsius, now we see that the whole curve shifts to the left. And that means that hemoglobin is going to be binding to oxygen more tightly. When the tissue temperature goes down, this indicates that the tissues aren't active. And if they're not active, they don't need oxygen to create ATP. So hemoglobin, instead of releasing oxygen at that tissue, will hold on to the oxygen until it travels to another tissue that is more active and is producing more heat. Finally, we get to the third factor that affects hemoglobin saturation, which is called 2,3-biphosphoglycerate, or BPG for short. So BPG is a byproduct of glycolysis. If you remember what glycolysis is, it's the breakdown of one glucose molecule into two pyruvic acids. We're going to talk about this more when we talk about metabolism, but during this process, we have ATP that's being produced, but at the same time, this BPG is also produced. This process occurs in the cytosol. It doesn't occur in the mitochondria at all. So red blood cells have no mitochondria, so this is the only way that they can produce ATP, by going through glycolysis. So the red blood cell produces a lot of BPG. Now, BPG has a direct effect on the oxygen binding and release. The higher the BPG, the greater the oxygen release. In other words, when there's a higher amount of BPG, hemoglobin will release oxygen and the saturation decreases. So when we have an increase in the levels, in the number of BPG, the more oxygen will be released and the lower the saturation percent will be. BPG is increased by things like exercise and growth hormone and epinephrine and testosterone and thyroid hormones. Anything that will increase the activity of the tissues will basically increase the production of BPG by the red blood cells. When the plasma PO2 is low for an extended time, the red blood cells are going to generate more BPG and more oxygen will be released from the hemoglobin, actually about 10% more than normal. BPG production decreases as the red blood cells age. So as the red blood cells are getting older, the less BPG will be present because the red blood cell won't be making it, and the more firmly hemoglobin binds to oxygen. And so this blood, if it has older red blood cells and fewer BPG molecules, will be pretty much useless for transfusions. So this chart is showing a summary of everything that we've talked about. So if we have more hydrogen ions, that means that the blood pH has dropped. Then the curve will shift over to the right and hemoglobin will release the oxygen into the acidic tissues. Same thing with increased temperature. We said if the temperature increases in the blood, then the hemoglobin will drop the oxygen molecule and decrease the saturation rate. We said that if there was an increase in the amount of BPG present, then the hemoglobin molecules would release the oxygen molecules and the curve would shift to the right. If we look at the PCO2, or the partial pressure of carbon dioxide, if there's an increase in carbon dioxide, the body sees carbon dioxide as kind of an acid, so the blood becomes more acidic. So the same thing will happen to the saturation if we have an increased PO2 as if we had an increase in hydrogen ions, and that means that hemoglobin will release the oxygen so it can bind to the CO2. Now on the opposite side, when we talked about things like a decreased hydrogen ion, that means that the pH increases. That means that hemoglobin is going to bind more tightly to the oxygen and the curve will shift to the left. Same thing if we have a decreased temperature, the curve shifts to the left because the tissues are less active, so hemoglobin is going to bind to the oxygen more tightly. And then also if we have an aging red blood cell and there's less BPG, then hemoglobin is going to hang on to that oxygen much more tightly. Hemoglobin. And fetal hemoglobin has a higher affinity for oxygen. Right? So that's why when mom's blood is coming through, passing by that placenta, even if mom's blood needs that oxygen, the hemoglobin is going to release oxygen so that the fetal hemoglobin can hang on to the oxygen and carry it to the baby, right, to the fetus. So it just has a higher affinity, and it allows the oxygen to cross over that placenta. Now I know you guys have heard of carbon monoxide. Carbon monoxide has a very forceful bond to hemoglobin. It's a very, very strong bond. It doesn't let go, and so it pretty much makes that hemoglobin useless, right? Because now hemoglobin can't bind to oxygen, and we said that in the plasma, oxygen just can't float around on its own. It dissolves pretty easily. When it's floating around on its own, it has to be bound to hemoglobin. So now the tissues don't get oxygen, And then death is going to occur pretty quickly because the tissues are going to die pretty quickly. If carbon dioxide makes up just 0.1% of your inhaled air, enough hemoglobin is affected that survival is impossible without medical assistance. Right. All right, let's talk about carbon dioxide. Carbon dioxide. So carbon dioxide travels in the blood in 3 different ways. First of all, carbon dioxide is converted to carbonic acid. We're going to look at how that happens, and then it'll be transported as bicarbonate. So the answer, we're going to look at the percentage of that. It can also be bound to hemoglobin, and it also can be dissolved in plasma. So let's look at the 3 individual ways. So first of all, 70% of carbon dioxide is transported as bicarbonate. Bicarbonate looks like this, okay? Bicarbonate. Now, so what happens is carbon dioxide has to diffuse into the red blood cell, and then it's going to, it will combine with water, and it will form carbonic acid. So you might as well get used to this equation because we are going to go over this equation quite a bit in chapter 27, right, and 26. So carbon dioxide and water combine together to form carbonic acid, and then immediately carbonic acid is going to dissociate into hydrogen ions plus bicarbonate. So the red blood cell will carry this bicarbonate around until it gets back to the lungs. And once it gets back to the lungs, the reaction will go in the opposite direction. This hydrogen will combine with the bicarbonate. It'll create carbonic acid. Carbonic acid will break down into carbon dioxide and water, and then you'll breathe out the carbon dioxide. Okay? So it's just a reaction that kind of goes back and forth. That is 70% of how carbon dioxide is carried, right? Then we have carbon dioxide being transported by being bound to hemoglobin. And 23% of carbon dioxide will be bound to hemoglobin. Okay? 23%. So that's the second most common way that it's carried. And then finally, 7% of carbon dioxide will just float around in the plasma. Okay? All right, so now let's look at some respiratory centers. And we're going to look at how do we regulate oxygen and carbon dioxide levels in the body. And so there's either local controls that are going to happen very locally in the body, or there's going to be central controls which happen by centers in your brain. So first of all, let's look at local regulation, right? We've talked about this before. So at the alveolus, if you have a lot of oxygen, the local control will be that the blood vessel will dilate. It wants to go to the area where there's more oxygen. If you have less oxygen in the alveolus, then those blood vessels going to that alveolus are going to constrict. So that's not anything new. We've already talked about that. And this is called perfusion. This is perfusion. Okay, capillary perfusion, pulmonary perfusion, however you want to talk about it. But that's perfusion. So that's local control. We have another local control that's called alveolar ventilation. And so this happens locally too, but it's not the blood vessel that's going to change. It's going to be the bronchioles. The bronchioles are going to either dilate or they're going to constrict. So when you have blood vessels with a high PO2, or with a high CO2, then the bronchioles are going to dilate going to that blood because they know we have to get rid of that carbon dioxide. So carbon dioxide will leave, diffuse the blood, and move into that alveolus. In the exact opposite way, if the blood vessel has less CO2, then those bronchioles will constrict because they want to try to keep the carbon dioxide in the blood, because you want to keep the carbon dioxide in a certain level. It should be within a certain range. So alveolar ventilation is all about the bronchioles, whereas perfusion was all about the diameter of the blood vessels, right? And it's still, they're both very local. Okay, so the smooth muscle, in other words, here around those bronchioles, they're very, very sensitive to CO2, right? So they're going to respond based on what the CO2 levels are. Okay, so now if your activity levels increase, and then this local regulation can no longer meet the demands, then we have these other central areas in your brain that are going to kick in, and they're going to help to increase the respiratory rates. So we're going to look at those next. So we have the Okay, so here we have all of the centers right on here. First of all, in the medulla oblongata, we have what are called the respiratory rhythmicity centers. Respiratory rhythmicity centers. So these are involuntary. There are nuclei in the reticular formation of the medulla oblongata, and they are going to control the minute volume. How much volume of air are you bringing in every minute? And they're going to control that by either increasing or decreasing the frequency and the depth of your breathing, okay, of pulmonary ventilation. So they're going to control, they're basically controlling the muscles of respiration. So we've got the main muscles, the primary muscles, which are the diaphragm and the external intercostals. And then we have the accessory muscles. So these centers are controlling the muscles. So let's first talk about the dorsal respiratory group. The dorsal respiratory group is it controls the diaphragm and the external intercostal muscles. It's going to function in every respiratory center, and it functions as the inspiratory center. So when we contract those muscles, when the dorsal respiratory group sets the pace to contract those muscles, then you're going to get inspiration. And then those muscles relax, and then you get expiration. And then those muscles contract, and you inhale, the muscles relax, and you exhale. So that's the dorsal respiratory group that's just setting that normal pace, okay? The ventral respiratory group, on the other hand, this controls the accessory muscles. So this isn't going to be during quiet breathing. The dorsal respiratory group works during quiet breathing, but it also works during forced breathing. The ventral respiratory group is only going to be active during forced breathing or when breathing demands increase, right? So they're responding, this ventral respiratory group, it's still in the medulla oblongata, it's responding to baroreceptors and chemoreceptors. And they're telling the ventral respiratory group whether it should be stimulated so that you're going to increase inspiration and expiration, or whether it should be inhibited so you're going to decrease inspiration and expiration. So the ventral respiratory group has both. It has an inspiratory center and it has an expiratory center. It has both, right? Okay. There's also, because it has both of those centers, because the VRG has both an expiratory and an inspiratory center, you can't, and again, this is only during forced breathing, you're not going to be able to have both of those centers in the VRG stimulated at the same time. So they have what's called reciprocal inhibition. So when the expiratory center is stimulated, the inspiratory center will be inhibited. because when you're exhaling, you're not going to be able to inhale, right? So they have this reciprocal inhibition is what they call it. Okay, so this is how your respiratory rhythm goes. Your DRG is stimulated for 2 seconds, and then you breathe in. Okay, and then the DRG is quiet for 3 seconds, and then you breathe out, right? Because the DRG, when it is active, when it's stimulated, the diaphragm and the external intercostal muscles contract, and then when it's quiet, those same muscles relax. So that's how we get this normal pace of breathing. Okay. In forced breathing, however, you're going to have an increase in DRG activity. So this activity increases in forced breathing, and then that stimulates the VRG. The VRG then has both that inspiratory and expiratory center, which will cause more forceful inhalation and more forceful exhalation. Okay. There are drugs and caffeine. There are certain drugs like amphetamines and caffeine that will increase the respiratory rate by facilitating these centers. So like amphetamines and caffeine, they will increase the respiratory rate by increasing the DRG and the VRG. Okay. But then there's other drugs such as depressants, like central nervous system depressants, like barbiturates, opioids, and they inhibit the respiratory centers. So they inhibit the DRG and the VRG. So when a person is ODing on heroin, that's what's happening. They're inhibiting these centers, and they are shutting down, and so your normal respiratory rate is ceasing, and then they stop breathing. Okay, so that's in the medulla oblongata. We also have respiratory centers in the pons. Okay, so in the pons, the dorsal respiratory group sets the normal rhythm and pace. In quiet breathing, the VRG sets the normal rhythm and pace. In forced breathing, it influences the DRG. But the pons has centers that will adjust the rate and depth of the respiratory centers in the medulla, right? So it influences the medulla. And there's 2 centers. The first one is called the apneustic center. Okay. So the apneustic center has an inspiration center. It will increase inhalation. It increases the intensity or the depth of inhalation. So when the apneustic center gets stimulated, it's going to increase the depth of inhalation. Okay. Then the other center is called the pneumotaxic center. And the pneumotaxic center will inhibit the apneustic center. Okay. So if it's inhibiting inhalation, it's going to be promoting exhalation. So that's what the pneumotaxic center does. If there's damage to this area, then you're going to have an increase in inhalation because there's nothing there to inhibit the apneustic center. So a person might inhale and then maintain it for 10 to 20 seconds before exhaling because the pneumotaxic center is not there to inhibit the apneustic center. All right. There is a condition that we call SIDS. That's also known as crib death. A lot of times not a lot of times, but when we do see this, we see this in any infant from 1 month to 12 months old. Kills about 2,200 infants a year. There's a lot of different statistics about it, like it happens between midnight and 9 a.m., so it happens in the middle of the night when parents don't know. It happens in fall or winter rather than spring and summer. So there's some different statistics that they've been looking at, but the infant suddenly stops breathing, they turn blue, and then they start to relax. They think it might be genetic, but basically they're saying that these developmental centers have not been developed as much. They're saying that the respiratory centers are not developed very high at those ages. Okay, so let's look at some things that will modify those centers. So first of all, we have receptors. There's a lot of different receptors that are going to be stimulated by changes, and then they're going to change the activities of the respiratory center. So we have chemoreceptors, we have baroreceptors, and we have stretch receptors. Okay. Then we're going to look at some other things like physical or chemical irritants and some emotional things, and we're going to see how that can influence the activity of these centers. So let's first look at the chemoreceptors. Chemoreceptors are sending information back to those centers in the medulla and the pons through cranial nerves 9 and 10, right? Glossopharyngeal and vagus. That's what sends the information back. Cranial nerve 9 is sending information back from the carotid bodies. So in the carotid artery, and cranial nerve 10 is carrying information back from the aortic bodies, so then back from the aorta. And they're both going to be carrying information about oxygen, so the PO2, the PCO2, and pH, right? Okay. So we'll talk about this, some specifics about that in just a second. Let's see. Now we'll go over some of that right now, actually. So in order for those chemoreceptors to really make a difference, the PO2 has to drop quite a bit. The PO2 would have to drop to around 60 millimeters of mercury in order for those chemoreceptors to really be sensitive to that. And so when you have that low of oxygen in the blood, the chemoreceptors are going to increase the rate of breathing, which makes sense. You've dropped how much oxygen you have in the blood. And so you need to get more oxygen back in the blood. So those centers are going to tell the centers then are going to increase the respiratory rate and the depth so that you start bringing more oxygen into the lungs, right? Okay. If you have, it talks a little bit about in your notes about if you have excess O2, then anytime you have high O2, you have low CO2. If you have excess O2, like if you're breathing in really deep and then you hold your breath, right? You have high O2 inside your body. The CO2 is driven down pretty low, and then you would be able to hold your breath quite long until you became unconscious if you really wanted to. Because whenever your oxygen levels content is really high, your carbon dioxide level is really low, because the hemoglobin can only bind to one or the other. So you're going to have the opposite reaction. High O2 means low CO2. So if you take a deep breath in and then you hold your breath, you've got a lot of oxygen in your blood. That means your CO2 levels are really low, and you can do that without feeling the urge to breathe until you pass out. And we see this in like breath holding spells of babies. Babies can, or young children even, they can stop breathing for like up to a minute, right? So we call that the breath holding spells of babies. And a lot of times they can pass out after that. Okay, let's look at some other things here with chemoreceptors. Another thing about chemoreceptors is that they adapt. And when they adapt, this can be a problem for people that have respiratory disorders. So with a person that has COPD, they're going to have a lower O2 and a higher CO2 level in their blood. And the chemoreceptors are going to get used to that, and then they're just going to change the set point for that. And then that can become a problem for them when they're trying to attempt to bring those levels back up to normal. Okay. Then pH. If we look at pH, anything that changes pH is going to affect respiratory performance. So for example, with exercise, when you are exercising, you are your muscles are creating lactic acid. So that's an acid which decreases pH, right? It decreases pH. When you have decreased pH, you're going to stimulate respiratory rate. Because remember, with a decreased pH, hemoglobin lets go of oxygen. Well, now you're going to have to get more oxygen in your body, so it will increase your respiratory rate. All right. Couple of disorders. Hypercapnia. Hypercapnia, so the name hyper and then capnia, that means an abnormally those notes are wrong here. It's an abnormally high CO2 level. So if you're looking at your notes, I don't know if you have this same version. It says abnormally low. It should be abnormally high CO2. Hyper means high, capnia means CO2. It's caused by hypoventilation. Okay, hypoventilation. So you're not breathing your respiratory rate is slower than it should be, which means you're not breathing out the carbon dioxide, which means the carbon dioxide is being driven down and kept inside your blood. Now, this is an important point that we need to know about when we talk about acidosis, right? So if you have hypoventilation and you're not breathing out that carbon dioxide gets backed up then, and then it stays in your blood. And so that you end up with hypercapnia, right? So different things can cause hypoventilation. You can have certain drugs will slow down your respiratory rate that we talked about, right? Also, like a brainstem injury. Okay, that can also slow down the respiratory rate. Okay. And when you have hypercapnia, then what it does is it stimulates those chemoreceptors because you have high CO2, and it'll cause the respiratory rate to then increase. So you would start breathing out more of that CO2. Okay. Obesity sometimes too, that can cause a person, just because of the pressure against the diaphragm, it can cause a person to breathe slower, which could also cause hypercapnia. So there's some different things. Then we have another one, the exact opposite, which is called hypocapnia. So hypocapnia means an abnormally low CO2 level in the blood. And this then is caused by hyperventilation. So a person's respiratory rate is too fast. That's what hyperventilation is. So you're breathing out too much CO2. So the CO2 is leaving, and now you have a lower level in your blood. You have a lower PCO2 in the blood. So if you have low PCO2 in the blood, again, this is important. You have to know this because we're also going to talk about like an alkalosis, a respiratory alkalosis that will occur when you are hyperventilating. Right? So the treatment for this then is to breathe into a paper bag, because when you're breathing into a paper bag, you're now breathing back in the CO2. You breathe out the CO2 when you're puffing, but then you're breathing it back in every time you inhale. Okay? Okay, so let's look at baroreceptors. Baroreceptors, like we know, they are monitoring the pressure. They do monitor blood pressure, but they're also monitoring the respiratory centers as well. So they affect the respiratory centers as well as affecting blood pressure. So when your blood pressure falls, your respiratory rate is going to increase, right? So why is that? Because when your blood pressure falls, you're getting less oxygen to your tissues. So your respiratory rate is going to increase to try to bring more oxygen into the body. Okay. There is the Herring-Brewer reflex. These reflexes that are baroreceptor reflexes, they're not going to be involved in quiet breathing, and they're not going to be involved when you have a tidal volume that's under 1,000 milliliters, right? So it's just going to be if you have a very low, a very high tidal volume, like you're bringing in way too much air. And what the Herring-Brewer reflexes do is they prevent overinflation and collapse. Basically what happens is there's two reflexes. There's an inflation reflex. So when you breathe in and your tidal volume is too big, then this inflation reflex is going to kick in, and it's going to inhibit inhalation, and you are going to then stop inhaling, and then active exhalation will begin. You don't want your lungs to burst because you're bringing in too much air. So that inhalation reflex stops the air from coming in if it gets too high, and then you exhale actively to get that out. Then there's also a deflation reflex as well, and that one is as the lungs start to deflate and they're deflating too much, then that exhalation center is going to be inhibited, and the inspiratory centers will be stimulated. So it's basically just a way to prevent overinflation by bringing too much air in. It'll stop you from inhaling and make you exhale. And it stops your lungs from collapsing, because as soon as you lose enough air, then exhalation will be inhibited and inhalation will be stimulated. There are some protective reflexes that I want to go over. Protective reflexes are when are going to occur. They're going to operate when you're exposed to toxic things, toxic vapors, toxic chemicals, mechanical stimulation. So let's talk about a couple of those. Sneezing. This is a protective reflex. It's triggered by when you have irritation in the nasal cavity. We have coughing. Coughing is when you are, it's going to occur when you have irritation in the larynx, the trachea, and the bronchi, so a little bit lower. Both of these reflexes involve apnea. And apnea means it's a period where respiration is suspended, and then it's followed by a forceful expulsion of gas, right, of air. So the glottis is closed during these, initially, the glottis closes, and then the abdominal muscles and the internal intercostal muscles are going to contract very hard, and air will blast out, opening up that glottis. Okay, that's what a sneeze or a cough is. But it has a period of apnea where there is no breathing at all when that glottis is initially closed before you get that expulsion of air. Okay, when that air does leave, it leaves at about 99 miles per hour when you're coughing and sneezing, so pretty fast. And then the last type of protective reflex is called a laryngeal spasm. So a laryngeal spasm can occur when there's a toxic, like a chemical irritant, or even when there's a foreign object, like, you know, you've heard of people that they are choking on like chicken bones or fish bones, right? So those bones get lodged right in the glottis area, and they restrict the, they are restricting the area, but it's that stimulus that closes that glottis to just close right up. And so it can close so powerfully that you would just, and not open so that a person could lose consciousness, okay, when that happens. There's some other voluntary things that can affect respiration, like rage and fear. That can cause you to increase respiration. Emotional states, which anything that stimulates the sympathetic nervous system. So fight or flight or fright, right? The sympathetic nervous system. What does the sympathetic nervous system do to the bronchioles? Constrict or dilate, right? It dilates them, so you get dilation of those airways. It dilates the airways. But then also emotional parasympathetic. When you stimulate the parasympathetic nervous system, nice, calm, soothing music, anything that relaxes you, then your airways are going to constrict. Okay, so definitely the sympathetic nervous system and the parasympathetic nervous system can affect your respiration. If you're anticipating exercise, you're going to increase your respiration. We said you also increase your cardiac output because your heart starts beating faster. And then you also have conscious control. Conscious control is necessary for whenever you are speaking, swimming, singing. All of these things are requiring you to breathe differently. You're not able to breathe in with that 2 seconds and then breathe in, 3 seconds and then breathe out. You're not able to do that if you're trying to do any of those things. Singing, swimming, talking. So you have to control your respiratory rate a little bit differently. In this case, this is conscious control. And we've talked about where conscious skeletal muscle control comes from. It comes from that precentral gyrus, right, in the primary motor cortex that we call the pyramidal system. Okay, pyramidal. Pyramidal. That's the voluntary skeletal muscles. Remember, they're pyramids because pyramidal because they look like little pyramids, those neurons in that precentral gyrus. Okay. All right, so then let's look at some changes across lifespan. And let's first talk about newborns. All right, so you have newborns, a newborn, when the baby, right before birth, right before that baby is being born, the pulmonary vessels are collapsed, right? Those vessels are collapsed, and the diaphragm and the intercostal muscles aren't even working. But as soon as the baby comes out and takes its first breath, then the diaphragm starts to contract, the external intercostal muscles start to contract, and the pressure inside the thoracic cavity decreases. As they're contracting, it's opening up that volume and decreasing that pressure. And then the lungs are going to inflate. That's what causes the air to come in initially. So when that happens, by that decreasing that pressure in there, blood is also going to get pulled into those pulmonary vessels because blood also wants to move from higher to lower pressures. So then blood gets pulled into those vessels, and then the other thing that happens is that there's these connections that start to close between vessels. So for example, the foramen ovale closes. The foramen ovale is that hole between the right and the left atrium. And then we call it the the fossa ovalis, right, once it closes. There's another connection that's called the ductus arteriosus. The ductus arteriosus is a connection between the pulmonary trunk and the aorta. Remember where those are? Here's the heart. You have the pulmonary trunk, and you have the aorta, and there's a connection between those two. That's called the ductus arteriosus. Well, on that first breath, as soon as the pressure decreases, that connection, those flaps are closed, and that connection is closed then at that point. Okay? Before birth, before that baby gave its first breath, the lungs were filled with amniotic fluid, okay, from the amniotic sac. Okay, then we're going to talk about elderly. So there's a couple of things with the elderly that you should know. They have a reduced efficiency of their respiratory system. Their respiratory system isn't working the way that it used to when they were younger. Elastic tissue deteriorates. Which means they're not going to be able to expand. Remember what we called expandability? That was compliance. So elderly are going to have decreased compliance because they're not going to be able to expand those their lungs, that alveoli. They're also going to have then, because they're not able to expand and bring in as much air as they want, they're also going to have a decreased vital capacity. So they have a decreased compliance because their lungs don't expand the way they should, and they have a decreased vital capacity because they're not bringing in as much air as they should. There's also arthritic changes that occur. Right? They get arthritis in the ribs, they get arthritis in the spine, and so they're not able to expand and lift that rib cage up, and that is going to also limit the minute volume. It's going to limit their depth of breathing and their rate of breathing. They're not going to be able to bring in as much air as they normally would, so that is also going to limit their respiratory performance. A little bit of emphysema is sort of expected at someone over 50 years old, but the extent of that emphysema, and remember what that is, that's destroying or damaging those elastic bands around the alveoli. Some of that is normal. However, it is going to be much greater in people that have smoked for a lifetime, even versus those who have never, who stopped smoking, years prior. Those who have never smoked have a much higher lung capacity into old age than those who have smoked even at all. But smoking cessation at any age definitely improves the future lung capacity. So a disability will occur. A person will be, they'll say they have a respiratory disability if their lung capacity is only 30% of normal. And normal is measured at age 25. So pretty high standards there. A 25-year-old's going to have a pretty good respiratory function. Okay. Death will occur if the respiratory function is only 10% of their lung capacity. Okay. All right, any questions then?